right, let's go talk about strokes. So strokes are on chapter 58, stroke, there's a whole chapter on it on page 1388. Parts of the brain and function you should probably get to understand. There's the lobes like parietal lobe, the temporal lobe, the frontal lobe, the occipital lobe. You need to know left versus right. And you probably should know about the Broca and the Wernicke's area, which I'm going to go research. So there's a hemorrhagic stroke and there's a ischemic stroke, and there's a TIA also. So our pathophysiology is basically time counts. I want you to remember that. Metabolism is altered within 30 seconds. It stops at 2 minutes, and cellular death at 5 minutes. So metabolism alters in 30 seconds, stops at 2 minutes, and cellular death within 5 minutes. You've got to know this because you've got to act fast and understand why. Numera, that's just with like infection, I guess, or something like it. I don't explain. There's modifiable and non-modifiable risk factors, like non-modifiable, you can't change your age, you can't change your gender, you can't change your family history or stroke, of stroke or race. Modifiable, what you can do, however, you can tell patients obesity, infection, sedentary lifestyle, history of TIAs, oral contraceptives, disease, smoking, alcohol, drug use, female taking OCP. So all of those you can modify. Just remember that. All right. All right, there's a lot here. Okay. Let's talk about the types first. So transient ischemic attack is, it's basically a brief period of interruption of blood flow. Symptoms resolve within 30 to 60 minutes. Repeated TIs may damage the brain tissue, and symptoms of visual, motor, sensory, speech deficits, and diagnostic testing. So let's talk about each one a little bit. Speech, you could see aphasia, dysarthria, slurred speech temporarily. You may see motor weakness, facial droops, arms or leg drifts, hand grafts, ataxia, gait disturbance. With visual, you may see blurred vision, diplopia, blindness in one eye, and tunnel vision. So, yeah. And numbness. So, sensory is numbness, face, hand, arm, legs, and vertigo. So know you're what the transient ischemic attack is. And if they have that still means they're at risk for stroke. So teach that to the patient. Teach that to the person that you're taking care of that you need to monitor for that. All right, so ischemic thrombotic versus embolic. So ischemic is can be thrombotic or it can be embolic. It's higher in men. So thrombotic is the cause could be hypertension, atherosclerosis, the possible presence of protein in the CSF. So there may be protein in the CSF. It's gradual. 72 hours, infarction symptoms progress, cerebral edema increases. So there's differences. TIA is common with this one. Headache, speech, visual, and confusion first few weeks. You got to be able to differentiate the two. So it's very important. The cause, cardiac disease, AFib, MI for the embolic. So it's different. So cardiac disease, AFib, and MI are more associated with embolic because it's coming and dislodging in some random other area, where thrombotic was happening in the brain to begin with. So this one would be rapid improvement if it got removed, and sudden max deficit at onset, and paralysis expressive aphasia. So that one happens right at onset, whereas the other one's more gradual. So let's talk real quickly about hemorrhagic then. Hemorrhagic is the most fatal. There's types: subarachnoid, intracranial hemorrhage. Cause could be hypertension is the most common. Intracranial hemorrhage, vessel disorders, rupture, aneurysms. Subarachnoid hemorrhage needs surgery. Coagulation, trauma, tumors, hypertension, arteriovenosis, malformation. Higher in women. So hemorrhage is higher in women. Just remember that. Maybe think women are fragile. Well, that's not. Maybe that's being judgy, but whatever. That's just how I'm going to remember it, is maybe women are more fragile, but bursts, not as strong in general. So seizures, you may see LOC, deepening, stupor, coma. CSF is bloody because the blood. Sudden head trauma, gradual if hypertension. Permanent neurologic deficits, prodromal symptoms. So that means prior headache, eye pain, visual deficit. So headache, eye pain, visual deficit, and dilated pupils. Headache, eye pain, visual deficit, and pupil. And dilated pupil, neurologic deficits. All right, so now let's quickly just recap the nursing assessments. What are we going to assess, and what are we going to then we could talk about these clinical manifestations. So our cranial nerves, we got to know them really well. So there's 12 of them. Okay, so we have our olfactory, which is our nose. We got our eyes, which is optic, it's sensory. Oculomotor is all muscles except for all eye muscles except 4 and 6. So 4 is your trochleomotor superior oblique muscles. Your trigeminal, the 5, is sensory for the face, the sinuses, and teeth. The motor would be muscles of mastication. So mastication for trigeminal. Your abducens is 6, your external rectus muscles of your eyes. Facial is motor muscles of the face. Vestibulocochlear is number 8 for inner ear. Glossopharyngeal. This is the motor pharyngeal musculature, sensory posterior part of the tongue, pharynx, and tonsils. So I think of glossopharyngeal as like the gag reflex. So posterior part of the tongue, the pharynx, and the tonsils. The vagus nerve is 10. Motor, you want to think of your heart, your lungs, your bronchi, your GI tract. Sensory, heart, lung, bronchi, trachea, larynx, pharynx, GI tract. I said that. External part of the ear. Number 11 is the accessory motor. You want to think of your sternocleidoid, mastoid, and trapezius muscle. And then number 12 is your hypoglosopharyngeal, so the motor muscles of the tongue. Okay. So you also want to do secondary, like comprehensive neurologic assessments. Primary is the ABCs, cardiac, respiratory, neurologic. Also, there's an NIH stroke scale. So NIH is 0 means no stroke, the 1 to 4 is a minor stroke, a 5 to 15 is a moderate stroke, and 15 to 20 is a moderate to severe stroke. Now, that's all it says in my notes. I think it'd be interesting to look up the stroke scale to get a better idea of like who made it, why, what does it do, how do you intervene for these different levels. Okay. Now let's talk about systematically each clinical manifestation and the diagnostics, and then we can go to complications and interventions. So you want to look at their affect for these patients. They may be frustrated with mobility, communication, difficulty chewing, examples of mastication. So mastication was cranial nerve. Mastication. I knew this. Testing myself. Yes? Mastication. I'm trying to look for trigeminal 5.
Oh, you're supposed to put this on.
Okay, so I'm going to go put this on her. Okay, hold on. I have a video. Do you want to say hi to everybody?
No.
Okay. There you go. I'm going to go right back to work. It'll be all good. Okay, so trigeminal 5 is the mastication. So you want to look for that. So what else does it say in my notes? So magnified by depression, changes in body image, and loss of function. So they may have difficulty. So for affect, this is the topic that I'm talking about still. So difficulty controlling emotions. They may be emotional response, may be exaggerated or unpredictable. So you want to think of your frontal lobe. Your intellectual, memory, maybe in the left, judgmental. So in the left, you're going to be affected with memory, emotional stuff. On your right side of the brain, it's judgment, right strokes, impulsive, and left cautious. So cautious for impulsivity, and they're not thinking. So right stroke affects the right side of the brain, and left affects the memory. So that's for intellectual. So motor, what are we gonna be looking for motor? Is reflexes may be altered, like hyperreflexia can go both ways. Apraxia and agnosis. So agnosis is unable to use an object correctly, and apraxia is unable to carry out purposeful motor activity or speech. So apraxia is purpose. Think of P for the purpose, and agnosia is the object. So gadgets, objects, inability to use objects correctly. All right. So then we have ataxia. They may have contralateral deficits like hemiplegia, hemiparesis. It works on the opposite side of the body. You may see muscle tone altered like hypertonia, hypotonia, incontinence, retention of the bladder or bowel. So it could go both ways. Respiratory diaphragm, it may be not working for motor. Swallowing, gag reflex. You really want to know your cranial nerves for that because hypoglossaal pharyngeal 9 affects your gag reflex. All right. So then we're going to talk about elimination. So elimination's inability to communicate that need maybe. They may have constipation, and mobility causes this, weakened muscle, dehydration, diminished response to defecation. So it could be multiple reasonings behind it. They may have frequency, urgency, incontinence. And then spatial perception. So henopsia or harmonious hemenopsia. So this is blindness on the same side of the visual field. So blindness of the same side of the visual field. Which is an interesting, I want to look that up and like how that would look like. Harmonious hemanopsia. That's interesting. All right, so then we got there, like I talked about earlier with the motor, agnosia and apraxia, P for purpose, G for gadgets, to not using objects correctly, and unilateral neglect they may have. So this is for talking about the concept of spatial perception, which is going to be affected by the right side of the brain. Incorrect perception of self. All right, so then like this is a really important one to know is the left versus the right brain, but first we need to talk about communication. So dysarthria is pronunciation, articulation, or phonation problems. So yeah, that's what dysarthria means. Dysarthria, pronunciation, articulation, phonation. Aphasia is the receptive, expressive, global. There's 3 different types. So aphasia is, let's just look real quick what aphasia, that's really important, really means. Okay. It could be a loss of ability to understand or express speech, so there's different types, basically. What it's basically saying is that you may have a problem expressing, being receptive, or globally just all together. So dysphagia, there's non-fluent, which is Broca's part. So Broca, we got to figure out where the Broca is in the brain. So there's Broca and there's Wernicke's. So the Broca is fluent. It's minimal speech activity with slow speech. Affects motor and expressive frontal lobe. Whereas, so this says it's in the frontal lobe area, the Broca's. Whereas the Wernicke speech is presents but contains little meaningful communication and affects the receptive and sensory loss of the left temporal lobe. So this speech is present but contains little meaningful conversation. So they're fluent. They're fluent, but it doesn't have much meaning to it. So speech contains little meaningful communication, affects receptive and sensory. Whereas non-fluent with the Broca's area in the frontal lobe is minimal speech activity with slow speech affects motor and expressive. So it's having a hard time expressing. And I'm going to do more research on this Broca versus the Wernicke's area, which is interesting. So that's dysphagia. Okay, so now we're going to talk real quickly about the right versus the left, and that's really important. So the right is the visual spatial awareness and proprioception. So like you think of your language impaired, sense of humor, your memory, disorientation to time, place and person, inability to recognize. Hold on. I think I mixed the two up. Yeah. I'm going to look this up. I'm pretty sure that they're mixed up. Left versus right brain. This is important. There's awesome pictures online. Like, super awesome. Yeah, so the right brain uses intuitive of problems, randomly tasks, create. Okay, the left brain. Hold on. Yeah. More analytical, more creative. That's interesting. All right, so I'm going to do more research on this left versus right thing. Okay, so I have here all right, impaired. Okay, so impaired sense of humor, memory disorientation to time, place, and person, inability to recognize faces, vision, spatial deficits, neglect of the left visual fields, loss of depth perception, behavior impulsiveness, lack of awareness, behavior confabulation, euphoria, constant smiling, denial, availness, poor judgment, overestimation of abilities, hearing loss, ability to hear tonal vibrations. That's when the right side is affected. If the left side is affected, you're going to have language problems, aphasia, agraphia, alexia, memory problems, deficits, vision and ability to discriminate words and letters, reading problems, deficits in the right visual field, behavior slowness, cautiousness, anxiety with new tasks, cautiousness, depression, feeling of guilt and worthlessness, worriness over future, intellectual impairment, quick anger, frustration, no hearing impairment. All right, so that's the difference with the left versus the right. So some diagnostics they would do for these patients is a cerebral blood flow. So cerebral angiography, carotid angiography, digital subtraction angiography, transcranial Doppler, ultrasonography, carotid. Okay, so there's a lot of tools. They may want to do a cardiac assessment. They may want an ECG, chest x-ray, cardiac, TEE, TTE. An additional extent of the involvement, they want to see a CT scan, CTA, MRI, MRA, CT, MRI, perfusion, and diffuse imaging. But you want to remember, because you need to find out, is this a hemorrhage or is this a ischemic? Because that makes a difference on how we're going to treat the patient, and it could be very dangerous to give them anticoagulants if they're having a hemorrhage already. You also want to see their CBCs, their PTs, their APTTs, their renal and hepatic studies, lipid profile, CNS analysis. So pretty basic. So for the complications, you want to look at their neurologic deficits, which we just talked about for clinical manifestations. Death is a complication if it's not treated quickly. Remember, time matters. Cerebral edema, which increases intracranial pressure, and just increased intracranial pressure in general. So nursing interventions are going to be with like communication. You want to assess, speak slow, calm, simple, pay attention to gestures, do not assume hearing deficit, face the client, alternate methods, try, accept frustrations. So this is just like after the fact of the whole scenario basically happening. This is not like first invention things you do. So integumentary, weak side, only 30 minutes. Good hygiene, emollient on dry skin, early mobility, special mattresses and wheelchairs. There's cushions, position changes, prevent breakdown. So this is how we're going to do with integumentary. Now we're going to talk about coping. Coping, calm environment, avoid shaming, sexual function. You may want to discuss sensory, diplopia, eye patch, protect eye injuries, right brain, stroke, higher risk of injuries, simplify steps to break down into steps, non-slip socks, shave forgotten right side of face, dress weak side first, nonverbal cues, instructions, left side strokes, direct verbally best for comprehension, video, monitor, lower height of bed. So really depends on the side, and really understanding the clinical manifestations helps with answering these questions that we're going to get for the test. All right, so For musculoskeletal, range of motion, the weak side, special attention. You want to skin problems, prevent contractures. Hand, trochanter roll at the hip, arm to support with sling, lap boards to prevent shoulder displacement, avoid pulling the patient's arm posture, posterior leg, splint footboard, high top tennis shoes to prevent foot drop, and hand splints to reduce spasticity. So there's a lot going on here. So geriatrics, there may be more assessments, caregivers, community integration, resources, respiratory. You may want to suction by the bedside, side lying, oxygen. You want to assess their bowels, monitor their mental status, LOC, strength, reflexes, cardiac status, temperature, INO, seizure activity, atelectasis, respiratory airway obstruction. So it's really the same concept. For their urinary bowels, you want to assess their urinary constipation, urinary frequency, urgency, bladder training, avoid indwelling catheter, Kegel exercises, fluid intake, high fiber stool softeners, 2,000 milliliters of fluid, increase physical activity, same time daily for bowel movements. And then the last thing is nutrition. You want to make sure that they have good oral hygiene, swallowing, chewing, gag reflex, pocketing before beginning, oral feedings assistive, needs quick assessments like fluid electrolytes, may need IV, neck slightly flexed, monitor lung sound suctions, bedside, assess for coughing, minimize distractions, liquid consistency of honey, safety to use while eating. So these are all the things that nurses are going to consider. For global aphasia, you want to give them a very fixed schedule because they can't tell you when they need care at all. And it really comes down to, also there's preventative measures for all of this. So remember, for the TIAs, you want to prevent. So rehabilitative also is just talking about your PTs, your OTs, your speech, your maximum independence. For your musculoskeletal function, you want to teach them about cane walking. So I want to actually write that down, cane walking, because that's a really big one. You want to use the unaffected side, cane first, and then the affected side, and then the unaffected side. So use the unaffected side, then the affected side, then the unaffected side. So UAU. So unaffected side, cane first, then affected side, then unaffected side again. Eating, no drastic changes. Toileting, encourage range of motion for unaffected side, and passive for affect, reposition every 2 hours for VTEs. Dress the affected side, then the unaffected side. So you want to dress the affected side, and then the unaffected side. Occupational therapy, you may need to refer to physical therapy, transfer bed to chair, balance training, bowel and bladder training, high fiber, high fluid intake. So we're all getting tired. So constrained, induced movement therapy may help. And bow bath, something. So let's talk about the preventative measures real quick. This is a long one. You want to manage modifiable risk factors. So like fast. You want to teach them about the signs: facial drooping, arm weakness, slurred speech, time to call 911. You remember seeing that video that was like all dance and less, super exciting. Increased awareness of signs and symptoms. When they're saying increased awareness of warning signs, sudden weakness and numbness, face, arm, legs, it's really the same thing. Sudden confusion, difficulty speaking, understanding, sudden trouble walking, dizziness, lack of coordination, sudden difficulty in vision in one or both eyes, sudden severe headache with no known cause. Whoa, that's a lot of stuff. Okay, so health promotion may suggest alternative oral contraceptive because of the clotting and the risk factors of some of that, and quit smoking may be suggested. So drug therapy, you want to prevent thrombus or embolism, like an aspirin, maybe like a baby aspirin, like 81 to 325 milligrams per day, most frequent, like an antiplatelet. So also like your anti-cholesterols, Simvastatin, Loravastatin to help reduce the risk for thrombotic type, antiplatelet like clopidogrel. So there's different types, like warfarin, ticlopidin, agrinox, dipridomol. I can't spell right, but you should review those. There's oral anticoagulants like I talk about warfarin. So there's a few examples in there. So there's a few different ways how you would treat a TIA ischemic hemorrhage that I'm going to talk about, like I'm going to get it done real fast, you know. We're going to try to get through this. But obviously there's always more to research about. So TIAs, the transient ischemic stuff. So TIA stroke prevention. So carotid enterectomy, stenting, carotid artery, transluminal angioplasty, extracranial, intracranial bypass, surgery for aneurysm, risk for bleeding. So if you see any of this, they may be surgery before the actual thing happens. You post-operatively, what are you going to do as a nurse? That's what's important. You want to assess for neuro, blood pressure management, assess min of stent, occlusion, hemorrhage, minimize complications at insertion, site, hematoma, and infection. So yeah, you want to keep the leg, keep it straight. Pedal pulses, side of surgery. I'm gonna have to post-surgery. That's interesting. Okay. It's been a while since I studied this. All right, so promoting lifestyle changes. You want to quit the smoking, healthy diet, exercise, manage the hypertension, teach about the ASAs, the antiplatelet drugs like clopidogrel or warfarin. And you want to control their diabetes mellitus, like blood glucose. You want to keep it from like 100 to 180 milligrams per deciliter. All right, so ischemic. So ischemic is like your statins, your antiplatelets, your anticoagulants. Heparin is not advised after a stroke. ICP you want to manage. So how are you going to do that? You're going to basically elevate the head of the bed. You're going to head and neck alignment, avoid hip flexion, manage hyperthermia, prevent seizures, pain management, manage the constipation, some patients spinal drainage. So study ICP and you would understand what to do for this too. Embolic, you want to, so ischemic, you want embolic with AFib, maybe like warfarin. ABCs, neurologic assessment, blood pressure management, ICP. So ischemic worsens like 24 to 48 hours after, just keep that in mind. Fluid and electrolyte balance, avoid hypervolemia, too much cerebral edema, not too little, monitor urine output. So you don't want too much or too little, as it will increase ICP. Increase ADH, urine output decreases, avoid glucose water, can further increase ICP or cerebral edema. So you're keeping a watch for that. TPA also, no for screen CT, MRI first, before drug therapy. 3 to 4.5 onset. So 3 to 4.5 onset in intra-arterial TPAs has to be done within 6 hours. So don't forget that. So for hemorrhage, okay, so, oh my God, this took me forever. So finally, I'm at hemorrhage. Okay, so basically you want to manage your airway, your breathing, your circulation, your intracranial pressure. If you have an aneurysm like occlusion, clipping, coiling, hyperdynamic therapy, you have to stop the bleeding. Prior, you may want to do a calcium channel blocker, nimodine, hold if pulse is less than 60, or blood pressure is less than 90. So just keep that in mind. And after, you want to give vasospasms like phenylphedrine, dopamine, hemodilution to keep it contracted. Hemorrhage, seizures are prophylactically to avoid seizures. Ventriculostomies, that's also for hydrocephalus, but that's a whole exemplar in itself. You want to reduce intracranial pressure if that happens. And surgery, the GDC coils, the rupture AV, for evacuation of a hematoma, aneurysm, resection, clipping. So really that's everything. That's a lot of information. I totally understand. And hopefully I put some extra notes into the OneNote. So there's, with this video collaboratively, and that's really everything for stroke. And there's 3 things going on here. We can have a TIA, we can have a hemorrhage, we can have an ischemic, and even ischemic is 2 different types. It's like you got your embolic, you got your thrombotic, and really it just depends how you're going to intervene based on what the clinical manifestations are. So happy studying and good luck on the test.